we are honored, we are delighted, and I am personally thrilled to have you here today. Dr. Teperman will sort out the fact and the fiction on the corona pandemic. He'll tell us where we stand now, what we need to do, and what we can look forward to. That's a good one.
That's a tall order.
As many of you know, he's the vice chair of surgery and the director of transplantation at Northwell Health. He's an internationally recognized pioneer in liver transplantation and a professor at Hofstra Medical School. So with that, COVID-18, COVID-19, and what we need to know. Dr. Teperman.
Thanks, Judy. So please, everyone refer to me Lou. The only one who called me doctor was my mother.
Okay.
Because she was a proud Jewish mother. So let's go through what this thing is, the nomenclature, and then walk us forward. So this is a coronavirus, and viruses are small things. They've been around for a long time, and coronavirus has been around for a long time, and there are lots of different types of coronavirus. So one of the common colds is caused by a coronavirus. And you may have remembered before the acute respiratory syndrome that came out of Saudi Arabia, SARS, was also a coronavirus. And so that was a really big one. It made people very sick, and people were very worried about it. And that didn't turn into a pandemic. And that one was thought to actually harbor in camels. SARS-2 or COVID-19, it's not the 19th form of the virus. It is discovered in December of 19. So that's why they called it 19. It is in the same family of coronavirus. It is a RNA virus, and the viruses can be divided up into DNA and RNA, and then they're divided up into senses, positive and negative. And you guys don't need to know that, but it's just how they copy themselves. And so it is a positive sensed virus. It is an RNA virus. And the cool thing about it is, or the bad thing about it is, it has these spikes. And so you can see these spikes if you looked at it with an electron microscope. And those spikes are specifically designed to bind to respiratory cells. And so they bind in respiratory cells probably in bats. And they probably also bind in us. Discovered in China. Nobody manipulated it. It says the internet is unstable again.
Yeah, we just missed a little piece.
Okay. Well, a little piece of a virus is a big deal. So this virus was thought to jump from bats, and bats have been around a long time, and they live a long time, 30, 40 years, and their immune system can deal with viruses. Interesting enough, this virus then found its way to our shores, found its way to Europe from China. And why did New York, specifically Long Island, get hit so badly? And it's because everyone lands in Kennedy and LaGuardia. And then all those people work in New York and Long Island, they come back, and it's just taking the vector, which is very contagious. For a virus to be very contagious, it's good for the virus. And if the virus doesn't kill the majority of people, it's called a fit virus. So this is a very contagious and fit virus because the majority of people, it does not kill. And so, but we've never seen a virus like this before. We've had no idea how to deal with a pandemic. So, you know, we were listening to our friends in China and then in Italy and in Spain, how to deal with the virus. And we know it's respiratory and it can be aerosolized, and then there are droplets. So right now there's an argument about, can it actually give people the virus via aerosol? And I think you'll find out that over time, everyone's going to say yes. Droplets are bigger particles, so, you know, they have weight to them. You cough, you talk, and they they have weight and they fall down. And so if the further you are from someone that has the virus, the less likely it would be for you to catch it because it's on a droplet. If it's aerosolized, it means it goes in the air, and distance may not be as important. And so right now we believe that being outside is much better than being inside, and the contagion goes on. So what can you do? So a mask, if a virus is a respiratory virus, so right now there hasn't been a verified case of anyone getting a blood transfusion and transmitting the virus. So this virus, in order to replicate, needs to be in the respiratory system and bind. So what can you do? One, you can wear a mask. And so there are many types of masks. And what does the masks do? It cuts down on you getting the virus and you transmitting the virus. If you wear an N95 mask, it stops 95% of the particles coming in. So there's actually an N100 mask. It's not a big seller. I guess 95 was good enough. So, and healthcare workers will wear these masks when they're taking care of patients. Healthcare workers will wear gloves. They will wear a gown or a shmata. It's really not necessary to wear that thing, but it's part of the rules. And people will wear goggles in the hospital because there was 1 or 2 cases that may have been transmitted through the eye. I think this is sort of overkill, but the mask is really important. 6 feet is the distance for droplets. If you're outside and you're past 6 feet with someone, you're gonna be fine. So big crowds, bad idea. And the virus can affect young and old. The concept that it couldn't affect young is just wrong. And so we don't know. My favorite line, my daughter and son and wife hear me say this all the time. We don't know what we don't know. So I've been studying this thing since December, and really there's a dearth, a lack of really good information. So for instance, you get the virus, so the natural course of the virus depends upon probably viral load. So if you got 1 million copies or you got 10 copies, you would probably be much sicker if you got 1 million copies. So when people were very close together in the middle of the winter and someone was contagious and no one knew they had it and they were coughing all over their mate, they would fever or cough 5-6 days, and then your body decides to go, oh, my internet connection is unstable again. Then your body decides to go one of 2 ways. It decides to clear the virus, or it decides to cohabitate with the virus some more and build up more of an immune response. And we get rid of viruses via an immune response, a killing response of the virus, and we release, I call it cleaning agents or bombs. They're called cytokines. They come from lymphocytes, and a T cell goes after the virus and kills it. And so when these cells release things, they can make you sick. And so now I'm going to take you back 60,000 years to the Neanderthals. And so we're Homo sapiens. And when we came out of Africa and stuff, we mixed with Neanderthals and we mated. And the Neanderthals had genes that particularly protected against virus. And so there were lots of viruses. And so they had a particular gene that probably did very well for a virus then, but now that gene has a very strong lymphokine response, and it releases all these bombs, and you get very sick. It turns out that they've tracked the response to this 60,000-year-old gene that we've mixed with, and you can find in Homo sapiens, in some of the people that got very sick, this gene that's turned on from 60,000 years ago, and it's actually our response to the virus that's killing us. So what did the medical profession do? So the medical profession didn't know what to do, still doesn't know what to do. Gives supportive care. So you might have heard that there was a drug, hydroxychloroquine, that Trump was promoting. One, he's not a doctor, doesn't know how to be a doctor, shouldn't promote medicine. This is not a political commentary, though I can do that. But so he actually promoted a drug that the government made sure that everyone could get, and we revved up and made a lot of it before it was tested. And people were giving this drug with another agent, Zithromax, an antibiotic. And as it turns out, not only was the drug not helpful, but it hurt people and it caused cardiac events, and more people died by taking this drug than it saved. So total mistake, in the meanwhile, so that drug was no good. So then we tried treating with other drugs that would stop this response, and they blocked different lymphokines or interleukins. And so there was one against interleukin 1, one against interleukin 6, and one against TNF, which is tissue necrosis factor. All those are bombs that go off. So they had an anti-bomb. And it doesn't really look like they work, but the data is still out there. And then people tried to work on a drug that would be an antiviral. And so an antiviral drug, a direct acting antiviral drug, is remdesivir. And that prevents the replication of the virus. But if you're already overwhelmed with the virus, the drug doesn't work. And that drug was brushed off. It used to be a drug for Ebola, and it didn't work. So that drug probably helps out if you're mildly sick with the virus. And so now if we do earlier testing and you find that someone's mildly ill or asymptomatic, that drug may help in decreasing the viral load. But if you're really sick, it doesn't work. If you're on a ventilator, it doesn't work. The key is not to get on a ventilator. So they want to put you on a ventilator, say, put me upside down, have me lie on my belly, give me different levels of oxygen, and let's try other things. What other things can you do? So there's convalescent serum. So people who recovered from the virus, like my son, if you had a high level of antibody, it was thought that you could take the serum, take the plasma out of those people, and give it to the people who are sick. Probably help a little bit are remdesivir, the direct-acting antiviral, and the convalescent serum. Now people have been looking at steroids. So steroids didn't work at first. So the steroids are stuff to use to stop the bomb from going off. And so people were trying prednisone, prednisolone, solumedrol, solucortef, and steroids are not all the same, and they have different effects. And so there's another steroid that's given often for patients that have neurological disorders, decadron or dexamethasone. And so dexamethasone has now had a question of being shown to be positive to help when that bomb goes off to make the response less virulent. Because a lot of the response that we're seeing is what's killing the host. And so when you look at the lungs of an autopsy specimens, the lungs have been destroyed, not necessarily from the virus, but from our natural response to the virus. So New York was very smart. It was late to the game. But I think Cuomo did a great job, and Michael Dowling, heading the task force of the hospitals, did a great job in uniting the hospitals, getting them PPEs, and making sure first that the healthcare workers had a very low prevalence in the hospital of the disease. And what do I mean by that? So at Northwell, we tested the providers in the hottest COVID unit. So one of them was mine, because we turned the transplant unit immediately over into a COVID unit. and only 3 to 6% of those healthcare workers through the entire 100 days ever came down with the virus. So that meant the PPE was working. And now we take temperatures of people who come into hospitals or synagogues or churches or schools. That's a mandate, a CDC mandate. Most of them will not have a fever, but taking a temperature is a good way to screen out people. It's actually interesting. The TSA has been taking temperatures of people for the last couple of months, and no one's come back positive for the virus or hot on the screen. But it is a good idea, and at least tells people that you're doing something and you're being safe. The next thing that you do is you ask people questions. So, do you have a cough? Were you around people that have had a cough or had a virus? Did you lose your sense of smell? Remember, I told you that this virus, those barbs, those spikes, bind to the respiratory nasal pharynx. That's why you do what I call a brain biopsy to test to see if you're positive. You stick a long Q-tip into the nose. They don't call it a Q-tip, but I'll call it. And you try to do a brain biopsy. You go all the way as high as you can get. And that's where the receptors are. It's called ACE receptors are for this virus. That's why that's the best test. Testing saliva is not necessarily the best test. There are many tests out there. Right now, the best test is to measure the RNA of the virus, and that test takes a little while to come back. What happens is you get the virus, it's an envelope virus, you get those pieces, you heat them up in some medium, you replicate them, and then you can tell if you're positive for the virus. There are quicker tests. They'll look at broken pieces or antigens, little proteins. They're not necessarily as good. And then there are antibody tests. So when you get a virus or you get sick with anything, hopefully your body makes antibody. Not all antibodies are protective. Not all antibodies convey immunity. That's why when you get a vaccine, it doesn't always work. And you got to get 2 or 3 boosters for it to work. So we know we need to make antibody against this virus. And the way you make antibody to respiratory viruses there are 3 different classes. And the first one starts with IgA. And then that's really what you get in a respiratory virus, but no one tests for that because they're all over the place. So then there's IgM, which is 5 IgGs stuck together. So you don't need to know that. What you need to know is that the IgG antibody is prevalent in people, at least 90% of people after they've had the virus at 30 days. So you'll make antibody, but no one's confirmed this yet. But 30 days, it looks like the time that at least 90% of people will have antibody. So what is the demographic of the United States, and what is the demographic for all of us? So the denominator is what's important. So when we weren't testing anybody, the only people we had enough cultures and swabs to test for are the ones we believed were sick. And so of the sick people that we tested, about 50%, 30 to 50% were positive. But that has nothing to do to the asymptomatic denominator of the entire population of the United States. So I don't know how many people we are. We're like 330 or 350 million. We're doing the census. Half the people are running away from the census. So, but let's say, someone probably knows on this phone, let's say we're 340 million people. So right now we know, so let's say it's that at least 3 million people in the United States have the virus. So let's say that's 1%. So in order for us not to convey this virus to anybody else, to have enough immunity, 70% of the population has to have antibody. So we're at like 1%. We need to get to 70% to get rid of the virus. So you could do what they did in Sweden, which is let everyone get the virus, and they still only have 1% of the population have the virus. Or you could vaccinate. The only way we're going to get out of this thing is to vaccinate. So the country has picked, they have $10 billion. I think so far they've picked 6 which are, I think, 5 companies, 2 of which have never made a vaccine in their life, are going to produce vaccine in millions and millions of quantities, not knowing if the vaccine is going to work. But one of these 5 or 6 will, and by January, we'll have vaccination for the population. And we won't get through this thing until we vaccinate. So we got another 6 months. So what are we going to do? Well, we're not going to do what Florida and the Ozarks and Texas are doing, which is stop isolating, stop segregating, stop social distancing. We have to continue to social distance. And so what does that mean for a school or a synagogue? We have a very small synagogue. That space for in the sanctuary, I don't know what the committees are all deciding, but that space is too small to circulate air. If one person in there had it, everyone would get it. It would be dangerous at present to open up in a small synagogue. Zoom services are great, but when things do open up, I do believe that, everyone has to practice the rules, CDC guidelines, have a temperature screen, done, a questionnaire for people who are ill or not ill to see if you're ill, washing hands. So you don't really convey a lot of the virus by the hands, unless you are coughing or sneezing in your hands. The virus doesn't live so well on surfaces. And in the sun, the UV light hurts the virus. And when you're further outside, it's good. So you could hold services outside, probably be okay. At least for the summer. In the winter, it would be tough. Schools, the kids get the virus. So I have a lot of transplant patients, and so transplant patients get the virus worse. So there was at least in one paper a 30% mortality because they're taking all these medicines that immunosuppress you and prevent the immune response, but you need some response. So you may not need an overwhelming response, but you need some response. So the transplant patients were dying at a rate in one place in the Bronx of 30%. So I actually stopped transplanting, and people stopped doing things like chemotherapy, which were going to immunosuppress you. Now we're back. I can tell you the hospitals are safe. They are very safe. They are much safer than being outside. So, and people can get their procedures that they need to get done. So if someone's having a heart attack, they shouldn't be afraid to come into a hospital. But it is true that people that have heart conditions, that are morbidly obese, that don't have the O blood type, are more at risk for getting sicker with the virus. A, B, and AB present the antigens on the cell, and somehow that's related to the virulence of the virus. All right, so I think I lost you guys again. So the future looks bright, but I'm telling you it's 6 months away. So you guys now all get to ask questions, and so someone direct them. So okay. Judy, you direct them.
Okay. Raise your hand if you have a question. I have one that I would like to ask you. What about reinfection?
That's a great question. So I think there's a lot of bogus stuff on reinfection. So the virus hangs on a lot. And pieces of the virus that may not be able to be virulent or replicate or infect stay on in the body probably for an extra couple of weeks, but they're not infective. They're just broken pieces of the virus. So why do people say you could get a reinfection? It's because they get one test done, it's positive. The next test done, it's negative. And the next test done, it's positive. And they said, okay, I got reinfected. It's probably the variability of the test, that all tests are not equal, all swabs are not equal. And so right now, I think it would be, you never say never, but it would probably be very rare to get reinfected with this virus. Now, that doesn't mean in 6 months you couldn't get reinfected, because I believe the antibody is probably going to only last for 6 months. But I don't know. Nobody knows. We haven't been 6 months into the flight yet.
I had heard something about a couple of cases in New Jersey where there was evidence of reinfection, where they tested clean for a while, and in both cases they showed the antibodies, and so the assumption was the infection was gone, but then
But
weeks later,
you have antibody and viral particles at the same
same
time.
time. Okay.
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 So the way of just because you made an antibody response doesn't mean you didn't clear the virus. Okay. So the virus and antibody coexist for some time.
Okay.
Then the antibody mounts, comes high, and then let's say the replicating virus goes away, but the broken pieces, the virus still trying to do something, but it's not infected. That's still there. That lasts another couple of weeks. So you probably, if you want to be 100% safe, it's probably somewhere between 2 and 3 months where you would have no viral particles running around your body.
Okay.
So some of the patients that have had terrible lung disease or lung cripples, I'm looking at 2 of them who need lung transplants. So they survived, but they need to have some of their organs replaced. So in kids, there's a crazy immune response that we think is Kawasaki's disease. And they get, suddenly after they've gotten rid of the virus, they get this immune response where they get red welts, they have some arthritis. And so there are lasting effects of this thing, in different age groups. But lungs, a bad lung infection and shortness of breath. There's also a heart issue with the virus. There are also GI side effects with the virus. There is anosmia, not being able to smell. The question of, does that come back fully? So this is a plague. We're the Jewish people. We know about plagues. So this is like locusts. I said
Yes.
the antibody, I believe, will last for 6 months. We don't know if it's protective. We believe it's protective. We believe it conveys some form of immunity, but everyone's antibody response is going to be different. And so there may be a certain level of antibody that is not protective. So we measure the titers of antibody. And when the titers really go down, it's just a protein. So your body begins to not make it anymore after the infection is gone. You have memory cells that may be able to come back with it again, but we don't know. So it's 3 to 6 months. And an antibody is a protein, so your body clears proteins. Certain cells still remember to make them. They're called memory cells. And so if the virus came back, you would like that memory cell to augment and make the protein. We don't know if it's going to do that. So the antibody that's remaining in you is probably around somewhere between 3 and 6 months. That's all we know. The level, the titer of the antibody is important. If you have a low titer, it's probably not going to be protective. If you have a high titer, it will. If you have a high titer, you probably had a bad infection. All tests are not equal, right?
Yeah.
And so the problem is, and this has to do with statistics and it has to do with the tests. There are at least 9, maybe 10 tests that measure the virus. And these are PCR tests, different companies, different swabs, different reagents. There's an Abbott test that's not as good, that's not as sensitive, that can be done in a half an hour. There is there are other companies that make other tests, Roche, and they're all different. So it depends upon which test you got. There isn't enough material around the United States for everyone to have one test. So if you get a test that's different the other day and its sensitivity is different, then true negative could be less. Right now, the negative predictive value of the test in the New York area is good. The reason is if the true negative is really low, so there are less people in New York State, then a negative is probably true. If we were overwhelmed with the virus again, the negative predictive value of that test, the sensitivity of that test isn't as good anymore. So right now, a negative is probably good, and a positive is real. Paul, if you are negative on a test, so let's say I wanted to visit you, and I hadn't traveled, and I, really social distance, and I didn't have anyone, and I really wanted to be careful, and I had a negative test before I saw you,
Yeah.
and I had no symptoms, no fever, I would be okay. I would be
Okay.
okay. So the concept is you can't contact trace everyone. Like down in Florida and Texas, they're overwhelmed. It's ridiculous to think. So kids probably won't get as sick. They have a different immune response than the older people like us, and so we're more at risk. But if they're all jumping around in the Ozarks or something, they're going to infect everybody, and then they're going to put other people at risk. Little children will probably get the virus, clear it. They may get this crazy Kawasaki's thing, but you may not even know it because they have colds all the time. So there definitely is a difference in the immune response in clearing the virus in adults, kids, teenagers. It's all true. I can tell you that all the hospitals are about to go broke. $30,000 doesn't cover a day in the life of a COVID patient in an ICU. When a COVID patient may go on dialysis, the hospitals are losing a fortune. You're going to see record numbers of hospitals go broke and go bankrupt. So hospitals, this is not a windfall for a hospital. This is a losing proposition. The hospitals have to, they have to furlough their employees who test positive. They've had to, they bonus people for a hazard pay. The hospitals are losing billions and billions of dollars. Each large, hospital system in the state of New York is going to be to the tune of a couple $1 billion. If you believe in Darwin, and if you believe in the apes are divided, and if you believe we came from the Africa, the apes are divided into 3 blood types: A, B, and AB. 3. There's no O. There's no absence of an antigen. So then we became human, a Homo sapien, and then we marched to the west. And as we marched closer here, the absence of an antigen in Western civilization, O, became more common. And it's probably because it's a protective effect on different diseases and viruses and as such. And so now in the US, in Caucasians, O is more common. So O is the most common blood type in the US, A, then B, then AB. And so O, as it turns out, is probably protective, at least a little bit on the virus, and less severe severity of illness is seen in people that have an O blood type. I think we have more older individuals in our synagogue, and so Zoom is a good way to do services and things, and until we get our stuff back together. The act of singing in a synagogue and projecting your voice is more aerosolizing, and more droplet forming, and can cause problems. I mean, I think people are beginning to see this now in the churches that have been open, down south, and then there have been large groups of individuals that you can prove by contact tracing got sick from the services. But it's a real interesting question, and we've got to get, we need a real good drug. We don't have it, and we need a vaccine.